Hi, I'm Dr. James Amos. I'm a consulting psychiatrist at the University of Iowa Hospitals and Clinics in Iowa City, Iowa, and this is yet another Geezer video. It's a dirty dozen on the common elements in psychotherapy, and a lot of it is based on a very important book, at least in my opinion, entitled The Art and Science of Brief Psychotherapies, A Practitioner's Guide. It's edited by DeJuan, Steenbarger, and Greenberg. And I'm going to read a very short selection from it. The book looks like this. It was published in 2004, and it's part of the core competencies in psychotherapy. So just a short selection from Chapter 8 by Roger P. Greenberg. It is true that psychotherapy sessions have goals and purposes different from those typical of friendships. Yet the ability to help someone open up to threatening thoughts and feelings, as well as be influenced by the interaction, is rooted in a process that establishes a certain amount of safety, security, and respect for the pain of another human being. Therefore, it is important to remember that psychotherapy is enhanced within any particular system when the therapist has good common sense judgment and hardy interpersonal skills. Not surprisingly, research has clearly supported the idea that there is more to effective psychotherapy than simply picking out a specific psychotherapy model and following the techniques in a robotic manner. So it's an excellent book. I've taken a lot of material from it for this particular Dirty Dozen. If you're seeing this on YouTube, as usual, I think it's probably best for you to go to my blog site, The Practical Psychosomaticist at jajsamos.wordpress.com, to get the full effect of the annotated slides and an appearance by C6 Steve, which you're just going to have to go to my blog site to see to believe. So let's proceed as usual with me looking and keeping track of the slides. There are about a dozen slides, and I'm going to go through them in a very quick way. And at your leisure, you can go through the slides on my blog site and take the quiz as well. I imagine that there will be lots of questions and some comments about a psychiatrist doing a presentation on psychotherapy, which is all to the good. I think it's very important that if the approach that I use is going to be both and, then I should do presentations and make videos about something more than just the medical and biological side of psychiatry. We're trained in psychotherapy, although we may not do it as frequently or get reimbursed for it, as well as the ones who do most of the psychotherapy, and those are social workers, psychologists, and other professionals. And slide 3 starts with a stab at the definition of what psychotherapy is. And it's really a way of fostering or facilitating change in the development of self-awareness in people who are contemplating change. It can be psychodynamically informed, meaning that people can look back at their childhood and early upbringing, role models and such, and sort of figure out what happened along the path to becoming what one is today. It can happen between patients and psychiatrists. It can happen between patients and psychologists, social workers and chaplains. It doesn't have to be in the context of a formal therapy encounter. The next slide, slide 4, is about what variables and relationship factors are important, and what is the importance of specific factors in psychotherapy to foster change. As it turns out, patient variables account for about 40% of improvement. It isn't so much specific techniques of the specific psychotherapy philosophy or style. The ability to relate psychological mindedness, motivation, the capacity to identify a central workable problem, and readiness to change. All are brought to the table and account for a great deal of improvement in psychotherapy. Only about 10 to 15% of people who undergo or undertake the psychotherapy road actually take action. And in fact, there are only a very few visits that patients actually end up attending. Anywhere from 1 to 4 is an average number of visits to the psychotherapist. So it's very important to try to put as much into 1 or 2 or 3 visits as possible to help move people forward. Relationship factors account for about 30% of the improvement. Therapeutic Alliance is very important. Getting the nod is how I heard it put by a therapist many years ago in an academic conference. Getting the nod is one way of putting developing a therapeutic alliance, which includes a mutual agreement on goals of therapy and engendering a mutual trust and acceptance. Slide 5 is dealing with other relationship factors that are important in change and in psychotherapy. That can be catharsis, which is a word for the release of emotional tension that can happen when people unburden themselves to someone they trust. The identification of the therapist as a role model is another factor. The sparing use of interpretations or explaining to the patient what you as a therapist think is going on and why you become the particular person that you are today. It's important not to overdo that aspect of psychotherapy. Slide 6 is about placebo, hope, and expectancy effects, which are very important in fostering improvement in psychotherapy. They account for a significant portion of the treatment effect. And they're not equivalent to doing nothing. Placebo does not mean nothing or no effect. It's part and parcel of how a therapist may present herself or himself. And it's about countering the demoralized state of patients who enter therapy. There's a therapeutic setting, and there is this therapeutic story that plausibly explains problems in a way that fits with a patient's belief system. These are all very important in fostering change and completing the psychotherapy experience. A word about the motivational interviewing style, which is not so much a psychotherapy model itself, but a model of the approach to meeting with another human being, respecting that person, and where they are in the road to change. Not everybody is ready to change. And a therapeutic style, motivational interviewing, is intended to be a way to help clinicians raise the patient's awareness of how it's possible to fluctuate between opposing behaviors and thoughts. And it emphasizes validation, reflection, and reframing. It accepts the yes but that we're all prone to doing without butting heads. And this is, the major source for this is from Miller and Rolnick's Motivational Interviewing, published way back in 1991. And it's sort of married to the stages of readiness to change model. Pre-contemplation, hey, I'm good, I don't think there's a problem. Contemplation, yeah, you know, I guess I got something going on here that I need some help with. Preparation, all right, I'm ready. And action, bring it on. And termination, meaning, you know, I'm at the point where I can cope now, maybe on my own. So just touch base briefly with you about some major models or styles of psychotherapy: the cognitive, behavioral, interpersonal, and psychodynamic approaches, which consist of, in terms of CBT, or cognitive behavioral therapy, a focus of treatment tends to be on internally based cognitions and challenging unhelpful or harmful thoughts and behaviors. It's time limited. Interpersonal therapy focuses on how interpersonal communication patterns with others may lead to problems and symptoms of depression and anxiety. It's also time limited. The psychodynamic approach does actually look back to the past, and it focuses of treatment tend to be on understanding the contributions of early life experiences and how unhelpful and harmful behaviors can develop from those. They can be lengthy psychodynamic approaches and can be open-ended. The essential operations of psychodynamic psychotherapy sound fairly familiar and applicable to many types of psychotherapy. The accepting component is one in which the therapist affirms the patient's past and present, validates the subjective experience of a person and what they're going through. Understanding. A therapist in this component appreciates both the conscious and unconscious contributions to the patient's emotional problems in the here and now. And explaining, kept to a minimum, the therapist expresses through interpretations, which takes practice and understanding and patience, his or her understanding of what's going on with the patient at a particular time. Integrating therapies is probably what many experienced therapists do. They are skillfully staged combinations of approaches, which may be more successful than using any one particular style alone. So the cognitive behavioral and interpersonal approaches might be used first or in the beginning stages for more immediate symptom relief. And later on, psychodynamic approaches can be used to help people understand what they've been through and the whys and wherefores of exploring the need for change. Now, how about psychotherapy on the run, which is how consulting psychiatrists like myself function, and how trainees learn to communicate with patients on the wards and in the general hospital. This is actually a slide that I'd encourage you to take a look at in greater detail, and it's about a presentation that a colleague of mine, Dr. Bruce Fole, gave in early May of 2011, talking about microtherapy. He titled the talk "The Accidental Psychotherapist," and it's an unpublished presentation that he gave at a departmental presentation. So I'd encourage you to read that. The first rule, which I really like a lot, is getting the patient's buy-in, which means, in Bruce's words, don't start rowing until the patient gets into the boat, and stop rowing if the patient falls out of the boat. You can go ahead and read the rest of them. The last slide, of course, are the references and resources. I hope you've enjoyed this little excursion. It's a very brief overview of what many experts believe the common elements of psychotherapy are, the most important anyway. And if you have comments or questions, which I expect you to have, please don't hesitate to come to my blog site and let me know about them. Well, until next time, be well.